Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Managing Medical Legal Liability for High-Risk Patients. And our presenters are Pat Lincor, Associate Commissioner, Division of Addiction Treatment and Recovery for New York State OASAS. Tricia Shell-Guy, General Counsel, Division of Legal Affairs for New York State OASAS. Grace Hennessy, Associate Chief of Addiction Psychiatry for New York State OASAS. And Kelly Ramsey, Chief of Medical Services for OASAS. They will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now, it's time to start the presentation and welcome our presenters.
I will go over the learning objectives for us before we have our first presenter. So today's learning objectives include discuss mitigation of risk from a treatment perspective, discuss mitigation of risk from a legal perspective, discuss mitigation of risk for suicide, and discuss mitigation of risk for overdose with medication for opioid use disorder, or MOUD, and engagement in care. Our first presenter is Pat Lincor.
Thank you, Dr. Ramsey. Pat Lincor, and I am going to talk a little bit about the treatment perspective. Within my opening here, also present a case and ask you to think about some of the questions that will be presented as you're listening to the other three presenters throughout this training. Supervision is really at the backbone of mitigation from a treatment perspective, making sure that staff have frequent open communication with the supervisor, and that the clinical supervisor is overseeing how staff formulate assessment and integrate that assessment into a treatment plan and the documentation of what that assessment has shown, as well as the documentation of any of the strategies that are being taken to mitigate risk, as well as to help the person move toward goals. So when they're seeking consultation with medical, a supervisor, mental health, and primary care, you want to be asking for each of your clinical staff how they seek this out, when they seek it out, how it's available to them, if they understand when a medical consultation is needed, a psychiatric consultation, and that they're working within the scope of their practice and not beyond it. And then also communication, making sure that the staff are communicating, with consent, obviously, but with those consents, making sure that family, other providers, and referral sources are aware of what's happening, and also that they're aware of what's happening in the person who they're working with external world as well. The documentation is also important in mitigating risk. You really want to make sure that you're documenting the reasons that you are making the decisions that you are, and how you're working with the person to make them aware of the risks, as well as the steps that are being taken to help them reduce risk. Training on documentation is important, and then corrective actions for staff who are not documenting well, or not, when a chart review might be being done, if you are identifying issues or concerns, that there are corrective actions taken either as a system or with an individual counselor. So this is the case that I mentioned earlier, trying to just get a sense of a person who I'm sure you may relate to or has been, this is a conglomeration of people who maybe in your treatment programs know one individual person, but she's a client of your agency and has been testing positive for cannabis, cocaine, and occasionally benzodiazepine over the past 2 months. This is following the death of her mother. She's had previously a 3-month period of really good stability on buprenorphine. The counselor and Anna explored a higher level of care, and Anna has declined not. She doesn't feel that she can or wants to go to that higher level of care. And the treatment team is concerned about her, particularly the benzodiazepine use. And so there's several opinions amongst the treatment team members about what the course of action should be. So we'll go to the next slide and see what each of the team members was thinking about this particular client. One person is worried about the vulnerable state that she's in, and believes that she needs an increased visits to the clinic and should be required to attend more intensive treatment in order as a condition of staying in care. Another thinks that she should drive her own care and that she should be consulted about what she thinks would be the most helpful to her, and that the team should be open to whatever threshold of care, including very low threshold care, that she is currently able to engage in, open to. And then there is another member of the team that believes that since the treatment recommendation that was made was refused by this client, that she is no longer in compliance with the plan and that she should be tapered from medication and discharged from treatment. So I think that you'll recognize that each of these opinions are likely opinions that you've met on treatment teams in your career, that people, have different kinds of experiences and opinions about how to provide care and how to react to a situation where someone is using substances in a way that could be provide some risk to them. Rather than choosing the statement that is the best one, what we want you to do during this part of the presentation, and then later as you're hearing from the case law, you're hearing from Dr. Hennessy and Dr. Ramsey about risk mitigation strategies. Think about this particular case and Anna, and think about what is the most likely way to keep her in care of those choices. What's the most likely to mitigate the adverse outcomes? Under what conditions would she be most likely to continue to be engaged and to reduce the likelihood of an adverse outcome, an overdose or fatal overdose, or other adverse outcomes that may lead to other kinds of hospitalization or inpatient care? What's most likely to lead to an adverse outcome? Which of those options would more likely lead to a crisis for Anna and something actually worse happening? And then if you were ever called upon to defend each of those choices, what would be your clinical rationale for the decision that you made as you were thinking about this? How would you defend that decision? Now, that's a part of risk mitigation, is being able to understand how you would defend the decisions that you're making. I'm going to pass this to Tricia Shogai for a legal perspective.
Thank you so much, Pat. So before we can discuss how to mitigate risk, it's critical for folks to understand what the risk is and where risk comes from. So the first key idea is knowing whether or not you actually owe a duty of care. Duty of care has been defined as the responsibility or legal obligation of a person or organization to avoid acts or omissions that could likely cause harm to others. Notice that definition includes not only actions that can be taken, but also inaction. Either of those is related to whether or not there's a duty of care. As a treatment provider, it's important to know who you owe a duty of care to. While this issue seems straightforward, it actually can be far more nuanced and complicated. You don't owe a duty of care to the public at large. For example, you have no obligation to seek out people who are in need of SUD treatment or substance use disorder treatment and insist that they get help. You do not owe a duty to someone that you don't have a treating relationship with. So if someone calls and asks you about your services and even schedules an intake, you have no duty to them if they never show up for the appointment. But you do owe a duty of care to a patient where there is a treating relationship. So if a scheduled but missed appointment doesn't establish a relationship, when does that relationship begin? So I think it's pretty obvious and clear that you owe a duty to a patient that's admitted in your program. And you likely owe a duty of care to someone where an evaluation process is started, whether in person or virtual, and whether or not services continue. As I said earlier, there's no duty established by, say, a phone call or an inquiry as to whether services are available. And a duty is not owed to a person if a third party seeks treatment on their behalf. If a patient is evaluated and not appropriate for your services, but requires an alternate level of care, you do owe a duty to assist the patient in finding that care. So when does your duty end? Your duty ends when your treating relationship ends. So if a patient is discharged, the relationship is over. Where a patient fails to show for appointments, a duty exists until and unless an administrative discharge is made. The next concept is trying to understand what the standard of care is. And the standard of care only becomes relevant once a duty of care is owed. So as we said above, once there is a treating relationship. Generally, the standard of care requires a person act with the care that a reasonable person would use in a similar situation. However, this standard is different in a treatment and a medical context because not all reasonable people have the skills and the training of medical and clinical professionals. So in a medical context or in a treatment context, the determination of what conduct is and is not reasonably expected of doctors and clinicians in these circumstances is not determined by reference to lay people. Physicians, other healthcare professionals, and clinicians are judged against the reasonable expectations of other similarly trained professionals. In this context, the standard of care requires that these professionals exercise the degree of skill and care that would be expected of an average practitioner in that professional's field. So the average addiction doctor in an addiction setting, the average CASAC in the setting in which a CASAC is operating. Failing to conform to these expectations is a breach of the duty that is owed and can lead to liability, generally in what is known as negligence. But of course, to find negligence, there has to be not only a breach of that duty, but the breach has to cause actual damages. So a breach of duty in and of itself doesn't cause liability. The patient on whom that duty was breached needs to have suffered some harm. Many states, including New York, have a locality rule that applies to physicians and other treating providers, that the provider must use a reasonable degree of learning and skill that is ordinarily possessed by providers in the locality where they practice. So providers aren't measured against every provider in the country, but against those that would be similarly situated. This was intended to recognize the distinction between, say, small rural practitioners who may not have access to the resources of providers that practice in large cities and academic institutions. The next concept I'd like to explore with you is something called respondeat superior. And this is a Latin term that literally means let the master answer. It's the primary legal theory under which a party who is not directly involved in providing services, care, or treatment can be responsible for the negligent acts of another. So this doctrine holds employers liable for the wrongful acts of employees, where the employees are acting in the course of their employment and operating under the control and supervision of an employer. The employer doesn't need to know that an employee was acting negligent in order to be held responsible. Whether or not employers are responsible for the acts of independent contractors depends on how much control the employer has over their conduct. If the employer, say, directs the work of that contractor, they can be liable for their acts. Direction can include things like setting work hours, assigning work tasks, and providing supervision. Medical malpractice lawsuits usually arise from injuries suffered by a patient in the course of a doctor-patient relationship. However, in practice, malpractice suits often implicate parties other than the doctor themselves. It is in an injured plaintiff's interest to sue multiple parties, especially if some of the parties have the financial resources to pay substantial damages awards. Since many doctors are affiliated with medical institutions or treatment providers that often have greater financial resources than the doctors themselves, such institutions may be named as defendants in malpractice suits. And the last concept on this slide is the statute of limitations. As most folks probably know, statute of limitations is a law that sets a time limit on how long a person or an entity has to start a lawsuit, or in the case of criminal matters, how long law enforcement has to charge an individual with a crime. In New York State, the statute of limitations for general negligence is 3 years. For medical malpractice, it's usually 2 years and 6 months from the time the injury occurred. And for minors, the time period begins after the patient reaches adulthood. So when it comes to thinking about what your liability is or could be, it's important to know the standards and the rules regarding the services that you provide. There are laws and regulations that govern licenses and credentials, meaning the ethics and the conduct of professionals and staff in your settings. When employees violate these and it causes harm, employers may be held liable. There are rules and regulations that govern how programs must operate. Programs that violate these rules and regulations can be held liable. If you have policies and procedures that violate the regulations or any laws, you can be liable for any harm that they cause. If you fail to train and supervise staff, you can be liable. If the regulations require a mental health or suicide screening and you don't do it, you can be liable if a person harms themselves. OASAS also issues guidance to providers in many ways, including through its Office of Medical Direction and via the Medical Advisory Panel. For example, throughout COVID, OASAS issued numerous guidance documents on things such as infection control practices and capacity limitations. And in February 2021, the Medical Advisory Panel, or MAP, issued best practices for long-term maintenance with medications for patients with opiate use disorders. These guidance and best practice documents become the standard of care for New York State substance use disorder providers. Failure to follow them puts providers at direct risk of liability if patients are harmed by that failure. New York State human rights law is another area where liability can stem. New York State has one of the most expansive human rights laws in the nation, and it does apply to treatment providers. Treatment providers are a public accommodation under the law, and as such, it is unlawful for you to refuse or withhold services or to deny reasonable accommodations to an individual based on race, creed, color, national origin, sexual orientation, gender identity or expression, military status, sex, disability, or marital status. Now, the one characteristic there that I want to specifically highlight and point out is disability. If a person comes to you with a disability, let's say a physical disability, you need to accommodate that disability in the treatment setting to the extent a reasonable accommodation can be made. Providers should have a reasonable accommodation policy in place, and you should be documenting any time an accommodation is made or denied and the reasons for such. Where reasonable accommodations cannot be made, providers must try and find a patient alternative care. Additionally, it's important to mention that providers that are funded by OASAS are obligated by both mental hygiene law and funding contracts to treat any patient that meets a level of care determination, regardless of their ability to pay. If a funded provider turns someone away because they do not have insurance and/or they cannot pay, they could be liable if that person were harmed. For example, if the person overdosed and sustained traumatic brain injuries. And then the final obligation, or the final point I'd like to make, is your obligation under your insurance contracts. Most providers execute lengthy contracts with payers in both the commercial and the Medicaid managed care arenas. These contracts contain extensive obligations on the part of the provider, including obligations to deliver quality care, utilize appropriate staff, treat particular individuals. To the extent providers violate these contract provisions, they open themselves up to liability from an injured party that is part of an insurer's network, as well as claims by the insurer for fraud and other misconduct. I also want to point out that there are many federal rules that may apply to substance use disorder providers. These federal rules prohibit discrimination based on certain classes, including disabilities, and impose obligations on certain types of providers to deliver care. Federal rules prohibiting discrimination in care include Title VI of the Civil Rights Act of 1964, the Americans with Disabilities Act, and the Rehabilitation Act. And then there are also obligations on some provider types to deliver care to any who are in need of emergency services. The Emergency Medical Treatment and Labor Act, or EMTALA, imposes affirmative requirements of care on patients that go to a hospital emergency department. These patients must be stabilized before they can be discharged. So now that we've explored how liability arises and how it applies to substance use disorder settings, I want to take an opportunity to share some ideas for how you might go about minimizing risks. First, all staff should understand the legal obligations providers have and when that obligation starts and when that obligation ends. Regular trainings, clear lines of supervision, and open access to compliance officers for all staff are critical. And I highlight that open access to compliance officers. I think I've spoken to staff many times and they don't even know that a compliance officer exists or what a compliance officer does. I do think it's important that providers recognize that staff should understand what compliance officers are for many reasons, beyond just personal liability. There are Medicaid rules to the extent that you're billing Medicaid that require people have access to compliance officers to report any cases of fraud, waste, and abuse, and that all staff understand that. Also, providers and their staff should understand their own limitations and not attempt to treat patients for whom they are not qualified. Staff should not be providing medical or clinical services outside their scope of practice, in areas where they are not trained, or in situations where they do not have the equipment to provide adequate services. To do so would be a breach of the standard of care. Appropriate screenings, regular review of patients' progress goals and objectives is critical to making sure that staff are appropriately treating individuals. Providers should also have robust referral networks and clear policies and procedures. They need to ensure that patients receive care in an appropriate setting, especially if they need to transfer a patient sometime after a treatment relationship has already been established. As I said before, if you've established a treatment relationship and you can no longer treat the patient, you need to make sure they are being seen somewhere where they can be adequately served. Having clear and updated policies and procedures and a documented process to show how they are communicated to staff is also very important. Especially in the event that someone brings a lawsuit against you, it serves as a defense to you if you can establish that you have these policies and procedures, that staff are trained on them, that they're updated regularly, that they're reviewed regularly, and that they're being followed. And when they are not being followed, that corrective action is taken and is being addressed. Monitoring adherence to policies, procedures, laws, rules, regulation, and guidance is also very important to minimizing risk. As I've said before, violation of laws, regulations, and guidance can be used against you as evidence of negligence, as can failure to follow medical standards of care that have been issued by your regulators. So now we're going to shift gears a little bit, and I'm going to turn it over to Dr. Grace Hennessy to discuss mitigation of risk of suicide.
Thanks, Tricia. So in this section, we want to discuss medical legal liability management associated with suicide risk. First, we're just going to review some basic concepts regarding suicide. The definition of suicide is a death caused by self-directed injurious behavior with the intent to die. A suicide attempt is a non-fatal, self-directed, potentially injurious behavior with intent to die, and that doesn't mean the patient has to die. The intent just has to be there. Suicidal ideation is just thinking about, considering, or planning suicide. Suicide of a patient can lead to litigation against any clinician. So anyone who's been involved in their care and didn't take the opportunity to review risk factors and try to mitigate them can be at risk of legal action. So since most suicides are planned rather than impulsive, the issue in liability management will rest on whether the clinician properly assessed the risk that a suicide would occur. Part of the reason why we're discussing this issue today is because suicide remains a significant issue in the United States. Between 1999 and 2019, suicide rates in the United States increased about 33%. On the positive side, the number of deaths by suicide decreased about 1.7% between 2018 and 2019. And the number actually decreased again by about 5.6% from 2019 to 2020. Despite these decreases, suicide remains a notable cause of death in the United States and was ranked 11th in 2020. Suicide is usually in the top 10, usually around number 9 or 10. But because of COVID, most causes of death dropped down in number, so suicide was the 11th cause in 2020. Deaths by suicide are more likely to occur among males, veterans, individuals living in Alaska and in the western and northwestern United States, Native American, Alaskan Natives, and non-Hispanic white populations, individuals aged 25 to 54 years old, and in terms of younger individuals, LGBTQ+ high school students are more likely to have suicidal ideation and make a suicide attempt compared to their peers. In terms of risk factors, there are a number of them, and the main ones are psychiatric and/or substance use disorders, chronic pain, history of prior suicide attempts, family history of suicide, family history of psychiatric or substance use disorders, exposure to violence, including physical or sexual abuse, adverse childhood experiences such as abuse or neglect, the presence of guns or other firearms in the home, recent release from prison or jail, legal or financial problems, exposure either directly or indirectly to other suicidal behaviors, such as that of family members, peers, or celebrities. So when we think about these risk factors and we think about the people who are more likely to die from suicide, it really covers a large number of individuals and a large number of individuals we see in our treatment programs. Despite these concerns, however, I want to stress that most people who have risk factors will not attempt suicide. So risk factors are a concern, but most people will not attempt suicide. So to speak a little bit more specifically about suicide and substance use disorders, I want to review a study by Lynch and colleagues that was done in 2020. And this was a study of 2,674 individuals who died by suicide between 2000 and 2013. In that study, they found that substance use disorders were associated with an increased risk of suicide, and it depended by substance. Unfortunately, in this study, they lumped drug together. They didn't break it down by different substances. So everything was split up. It was alcohol, tobacco, and drug. As you can see from the adjusted odds ratio, there are definitely elevated rates associated with alcohol use, tobacco use, and drug use. And then even more so when you get into the combinations of alcohol and tobacco, or drugs and tobacco. And individuals who use alcohol and drugs and tobacco had a quite high odds of risk of suicide. So again, very important to realize that our population is at risk. Because of this risk, OASAS supports and really embraces the Zero Suicide Initiative. The Zero Suicide Framework is an organizational level initiative that works to decrease suicide rates through universal screening, assessment, reassessment, and aftercare planning. The foundational belief of zero suicide is that all suicide deaths are preventable. Zero suicide requires that all relevant stakeholders take an active interest in reducing suicide in their entire agency. So this is a very busy slide, I know, but I'm going to go over it, and it provides a framework for the screening, assessment, intervention, and monitoring of individuals for suicide risk in OASAS certified programs. So if we look over to the left, really all patients should receive a universal screening for psychiatric conditions with the modified mini screen. And this actually, the modified mini screen and its use was something that OASAS advocated for and strongly recommended in a guidance that was issued in October of 2020 about the use of screening instruments in certified programs. We strongly recommend that the modified mini be used because it is a good general overall screen for psychiatric conditions and disorders, but it also contains a question particular to suicide. And that's question number 4, which asks, in the past month, did you think that you would be better off dead or wished you were dead? If someone says yes to question 4, so if we look at the second box on the left, or based on clinical judgment. So maybe someone says no, but you as the screener have a concern. We encourage you to move on then to administer the Columbia Suicide Severity Risk Scale, or the CSSRS, which is a brief questionnaire that rates suicide risk. So if someone says yes to certain questions on the CSSRS, that's considered either modified or high risk. And this is a point, depending on your training, you may want to consult with a supervisor, such as Pat discussed earlier. So you may want to call in a supervisor if you have a concern, and then you and your supervisor can decide what to do next. And usually at that point, you're going to refer to a licensed clinician working within their scope of practice, as Tricia talked about before, making sure this is someone who's qualified to do this. And that would include nurses, licensed social workers, CASAC, psychologists, psychiatrists, again, who have received the training to complete a risk assessment. If a suicide risk assessment is done, then you want to find out if really someone is in need of treatment. So in some cases, some people may need immediate treatment. So in the action plan, if they're at imminent risk, they may be referred to a CPEP if you're in an outpatient program, or if you're in an emergency department, you may move to have them admitted to the hospital, either voluntarily or involuntarily. And if there isn't an imminent risk, then you may want to set them up to get a comprehensive mental health evaluation as soon as possible, either within house. So if you're in an emergency room and it doesn't seem there's an imminent risk, you may want a psychiatrist or a psychologist to evaluate them further. Or if you're in an outpatient setting, you would want them to see either a psychiatrist or a psychologist on site, or refer them out. If people are at risk, you do want to do and if we look at the middle, you want to do certain steps. So the interventions, lethal means, and counseling and reduction, completing a suicide safety plan that has been created by Barbara Stanley and Greg Brown, and providing information about national, state, and local crisis interventions and contact information. And the treatment plan should address these issues as well. I'm not going to go over the information on the right in depth, but basically what that tells you is that if you're an inpatient or an outpatient, sort of what you want to do for individuals who've been identified as moderate or high risk going forward after that's been identified. And lastly, I just want to introduce people, if they don't already know, or make you more familiar with the Stanley Brown Safety Planning Intervention. So this is also called the Suicide Safety Plan. And it's a very, very simple document that creates a safety plan that focuses on different things that people can do when they are feeling suicidal. So the warning signs for feeling suicidal, internal distractions or internal coping strategies, or things that a person can do to take their mind off their problems without contacting another person. And the next step, the third step, external distractions, so people in social settings that provide support and distraction. Social support, who can you ask for help? Professional support, the names of professionals or agencies you can contact during a crisis. And then lastly, means reduction, or making the environment safe. So this type of safety planning is a very effective way to give people a tool to use when they are feeling suicidal or they feel a crisis is coming on, to help save their lives. And again, in helping people save their lives, you do mitigate your medical legal risk in terms of suicide. I'm going to turn this talk over now to Dr. Kelly Ramsey, who's going to take us through the next section. Thanks.
Thank you. So I'm going to talk about mitigating risk for overdose, and I actually didn't include any epidemiological data about overdose specifically, but I think at this point in time, everyone is probably pretty aware of recent data that was released by the CDC, which included 12-month data between April 2020 and April 2021, showing over 100,000 deaths, which is the largest number of deaths for a 12-month time period in the history of monitoring for overdose. So given that background, it's particularly important that we discuss how programs and providers can mitigate their risk for overdose in their patients. And really the best way to do that with respect to opioid overdoses, which account for the vast majority of overdoses overall, is to use medication for opioid use disorder, or MOUD, and obviously to have naloxone in the hands of people who may either experience an overdose or may witness an overdose. So let's go over some of the evidence for the use of medication for opioid use disorder, or MOUD. So on this slide, you see two graphs that essentially represent the same information, but they were done at two different points in time. So on the left-hand side is looking at data from 2003, and this was looking at detoxification with no maintenance of medication for opioid use disorder versus maintaining people on buprenorphine after detox and seeing what happened to them over time. We looked first at the group that went through detoxification only. 0% were retained in treatment over time. So in other words, after detox, if there was no medication that was used for maintenance, people left care. And 20% in that group died due to overdose. So again, talking about a large proportion of the population that unfortunately lost their lives because they weren't maintained on medication for opioid use disorder. In contrast, the group that was maintained on buprenorphine and followed for a year over time, 75% of those individuals were maintained in treatment and 75% were absent per toxicology results. On the right-hand side is looking at a similar study that was looking again at what happens when you taper people versus you maintain them. And this was printed in 2014. In this situation, people were maintained for a little bit longer. So they were looking at short-term maintenance on medication versus long-term maintenance on medication. And what they found is, again, even if you keep people on medication for a short term, once you taper them, they are basically lost to care and, again, at higher risk for overdose, as opposed to individuals that are maintained on MOUD who are more likely to be retained in care over time and are at lower likelihood of overdose. Continuing the theme of looking at the evidence for the use of MOUD, on the left-hand side is looking at a study that looked at heroin overdose deaths versus opioid agonist treatment. In this study, they looked at both buprenorphine and methadone. So this was a cohort in Baltimore, Maryland, and it was a cohort that was looked at between the years of 1995 and 2009. And essentially what they showed is that if you maintain individuals on either buprenorphine or methadone, it led to a 79% decrease in overdose deaths over time. So again, reinforcing that point that maintenance on MOUD will decrease overdose deaths. On the right-hand side is looking at data specifically about detox. And what this showed is that what we know is that detox really isn't a form of treatment, in other words, towards long-term care and long-term maintenance of either recovery for patients and or decreased risk for overdose. So detox in and of itself is a pause. Detox in and of itself is a pause in time. So basically, it's removing very temporarily someone from the environment in which they're using. However, if treatment isn't continued over time in some manner, shape, or form, then people are very unlikely to succeed, and they're at very high risk for overdose when they leave the detox facility and are not maintained on either methadone or buprenorphine. So this looked at, compared to the first attempt, the second attempt is 32% less likely to be successful. The third attempt at detox is 44% less likely to be successful. The fourth attempt, 47% less likely, and the fifth attempt, 59% less likely. So overall, 83% relapsed by 30 days in this group. So this is another study. This is a meta-analysis that came out in the British Medical Journal in 2017. And this was looking, again, people on methadone or buprenorphine in treatment and out of treatment and what their risks were. So this showed a reduction in all-cause mortality and mortality due to overdose. So there's 3 times higher mortality rate out of methadone treatment and 5 times higher overdose mortality rate out of methadone treatment. Those were the more significant findings compared to buprenorphine. So again, not only does it decrease risk for overdose mortality, but it decreases all overall or all-cause mortality when maintained on MOUD. So this was an article that came out in JAMA in 2020, and this was looking at comparative effectiveness of different treatment pathways for opioid use disorder. And this is a very busy slide. When you take time later to read the entire slide, you'll see that they talk about the methods of analysis, and I'm not going to go into that level of detail because I don't have time. But what I'm going to emphasize here is that the bottom line in this comparative effectiveness study of looking at different treatment pathways is that methadone and buprenorphine were associated with reduced overdose and opioid-related morbidity compared to no treatment. So what would be some other opioid-related morbidity? It could be endocarditis. It could be abscesses. It could be bacteremia. It could be a variety of other medical conditions that would be associated with opioid use and particularly associated with injection drug use. Notably, naltrexone, inpatient treatment, and intensive behavioral interventions for opioid use disorder were not associated with reduced overdose and opioid-related morbidity. The next slide is looking for the evidence for the use of MOUD plus access to harm reduction services. And I've posted the abstract on the left-hand side, but I'm going to get to the conclusion, which is most important. Achieving a 40% reduction in opioid overdose mortality required increasing capacity for treating with medications for opioid use disorder, or MOUD, improving retention on medication, and increased naloxone distribution. So OASAS has emphasized again and again, and particularly during the pandemic, has emphasized the importance of maintaining persons in care, maintaining persons on medications for opioid use disorder, and also about the importance of educating all patients, again, regardless of their substance use disorder diagnosis or their intended substance of use, about naloxone for overdose prevention. And these really are the key points in decreasing someone's risk for overdose. So again, we've talked about on webinars and in other forums about utilizing medication for opioid use disorder as a risk mitigation strategy, even in individuals who aren't primarily intending to use opioids, but are exposed to opioids because they're using other substances. So again, another strategy to think about utilizing in your patients. So a common question that's asked is looking at how long should persons remain on MOUD? And my answer is that it should be long enough for that individual patient. So as long as that patient is receiving benefit from taking the medication, the patient should stay on the medication. So it's not looking at perhaps something like, are all their urine toxicologies negative for opioids, and using that as a calibration of whether someone should remain on medication. But it's looking at how has that medication stabilized or benefited that patient. So that involves talking to the patient and determining how they're doing in their life. How are they doing with respect to the goals that they are hoping to achieve? Those goals may be very different. They may be different from what the treatment team thinks are the goals for the patient. So for example, for one patient, it may be that they want to get back to work, or they want to go to school, or they want to get their children back, or they want to get their teeth fixed. So there may be individualized goals that really have nothing to do specifically with their substance use disorder diagnosis. But if the patient is getting benefit from the stabilization that is associated with being on that medication, then the patient should stay on that medication. So it is different for every patient, but we clearly know from lots and lots of data that return to use and fatal overdose rates are higher for either shorter courses of treatment or for no treatment. So often when patients initially would come into care with me and they'd ask me, particularly a patient who was maybe a little ambivalent about going on to buprenorphine, they would ask me, well, how long do I really need to be on this for? And so I would say at a minimum, you want to outline with patients, particularly who are ambivalent, that they should remain on MOUD for stabilization for a minimum of 6 to 12 months. But often by the time that 6 month rolls around or the 12-month mark rolls around, people recognize that they've stabilized on the medication and then are often willing to stay on it long term. And so thinking about MOUD as a chronic medication or at least a long-term medication is a better way of thinking about it. So per one study, and I've only ever really seen one study that looked at the average duration on buprenorphine treatment. In that particular study, the average duration was between 8 and 9 years. So another way of framing it for yourself, for your coworkers, for your patients, is to think about opioid use disorder as a chronic disease and think about it like you would think about other chronic diseases. So many chronic diseases require medication chronically. So like a person with diabetes who needs insulin for life to manage their diabetes. We want to be thinking about MOUD in the same way. So again, long-term versus lifetime, but not short-term. And then the study on the right, which is a little bit blurry on the slide, it's not perfect, but it's just an abstract, but it again emphasizes that the longer that people stay on, they use the term MAT in this study, but MOUD or medication for addiction treatment, MAT, individuals are going to have fewer overdoses when they maintain medication. And even if people are imperfectly taking their medication, the longer that they are prescribed it, in other words, they have access to it, then any time that they take that medication, they are decreasing their risk for overdose. So this is another study that looked at the taking of benzodiazepines or Z drugs, such as zolpidem, and how that overdose risk in persons with OUD is partially mitigated by buprenorphine treatment. So another way of thinking about this, because a lot of providers are concerned when they see a person is either using benzodiazepines or even Z drugs illicitly, or they're being prescribed it but taking it in a misuse pattern, they're concerned about prescribing buprenorphine for them. They're afraid that this will lead to sedation. They're afraid of increased overdoses, et cetera. And the way that I think about benzodiazepines or Z drug use in combination with buprenorphine treatment is I think about if that person were using opioids illicitly, so whether those opioids were heroin, fentanyl that they were acquiring on the street, or whether these were prescribed opioid medications that they were misusing. When you're talking about a full agonist opioid and taking a concomitant benzodiazepine or a Z drug, your safety profile is going to be a lot better with buprenorphine as a partial agonist as opposed to full agonist use. So for people who are hesitant to prescribe buprenorphine when someone is, again, either prescribed benzodiazepines and using them correctly or prescribed benzodiazepines and misusing them or using benzodiazepines illicitly, you're actually providing a safer risk-benefit profile for that individual by prescribing buprenorphine for them than they would have if they were using illicit opioids. So again, helping to decrease their overdose risk. So this is the continuum of overdose risk, and this is looking at how the treatment continuum and how sort of the drug use and risk for overdose continuum interface. So looking on the left-hand side, it's looking at drug initiation, then moving to consistent active drug use, and then to a diagnosis of a substance use disorder. And a person can experience non-fatal overdoses, and if a person experiences a non-fatal overdose, they're at a higher risk of having a fatal overdose later in time. Now, we can intersect with that individual and their use at any point along that continuum. Before someone uses, obviously with prevention messages, we can interface with harm reduction at any point along that continuum. And then if and when somebody is ready for treatment, we can also intersect with that continuum and help support them in recovery. So really the best bet anywhere along that continuum on the left-hand side is using harm reduction practices and educating individuals about the risk for overdose with any street drug use. So if somebody is acquiring anything from the street, they're at risk of being exposed to fentanyl unwittingly. And so important, again, to be doing naloxone education and overdose prevention education with anyone who is actively using any substances, and or with family members, friends, or anybody who may witness that overdose. But having naloxone in the hands of someone who's actively using is really our best mitigation strategy. So how do we get naloxone into that person's hands? Any provider can write a prescription for naloxone to be filled at a pharmacy, and I would always write mine with 99 refills so that that person has access to it anytime they need it. You can become an opioid overdose prevention program through the New York State Department of Health, and then have naloxone on hand to dispense to patients directly, so they have it in hand when they leave your office. Or patients can go to a pharmacy and not have a prescription on file, but that the pharmacy participates in either the opioid overdose prevention program through New York State Department of Health, or through a standing order that they will dispense naloxone to anyone who walks into the pharmacy asking for it. So in thinking about the continuum of overdose risk, we also can't separate the social determinants of health. So we're healthcare providers as the substance use disorder treatment providers in our system, and it's important that we understand the interplay of the social determinants of health in our patients' lives. And even though many of the things that contribute to the risk for someone not only to develop a substance use disorder, but to have an increased risk for overdose, often those things occur before the patients get to our care, but that doesn't mean that we can't make an impact on those factors to help stabilize that person and help improve their lives. And probably one of the number one things we can help our patients with is having safe and stable housing. So looking at the right-hand side, we're going to talk a little bit about risk factors specifically for opioid overdose. So the first one is a history of substance use or misuse. And again, these may be individuals that are interacting with our prevention system, so not yet engaged in our treatment system. So for instance, recently initiated injection drug use is a particularly high risk for overdose. A person who previously experienced a non-fatal overdose, concomitant use of opioids, again, full agonist opioids and benzodiazepines and or alcohol, and intended use with non-opioids, therefore they have a lack of tolerance if they are exposed to opioids such as fentanyl and its analogs. Had one or more of the following mental health conditions, so severe psychological distress, mental health diagnosis specifically, been admitted to a psychiatric hospital, or increased depression, anxiety, stress, or trauma due to the COVID-19 pandemic. Had one or more of the following medical conditions: chronic pain, cirrhosis, pulmonary disorders, frequent or recent hospitalizations, physical disability, et cetera. Experienced one or more of the following life events or conditions: witnessed a family member overdose, been incarcerated, status post-discharge from an inpatient setting, homelessness in the past 90 days, unemployment, financial struggles, or social isolation. Low perception of harm, so based on their mode of use, so perhaps they've heard the internet myth that if they are smoking fentanyl, they won't overdose. Or again, they may be only intending to use methamphetamine and be opioid naive, yet are exposed to fentanyl unwittingly. And then lacked knowledge regarding opioid overdose prevention. So again, as I mentioned, a lot of times we are meeting patients downstream when we're providing clinical care. But in order to really make a difference in our patients' lives, ultimately, we need to remember that we have to influence those upstream and midstream factors that are affecting our patients' lives. So the more that we can do that in conjunction with work with community-based organizations and other providers that are providing other services for our patients, the more that we can support our patients and decrease their risk on the continuum of overdose risk. And just a reminder that recovery is individualized, and this comes from SAMHSA. I abridged it for our purposes here. So a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And some of the most important parts of recovery involve health, so overcoming or managing one's diseases or symptoms. So this could be a person who is pre-contemplative about their substance use disorder, but they also have hepatitis C, and they are being treated for their hepatitis C, and then that gives them hope towards their substance use disorder. So in other words, you treat and cure their hep C, and then maybe they're willing to take a look at their substance use disorder and perhaps make some changes there. I mentioned the importance of having a stable and a safe place to live. When you think about the hierarchy of needs that an individual who is actively using has, if they're homeless or they have an unsafe or unstable place to live, it's going to be very hard to stabilize with respect to their use or even look at their use or consider any changes in the patterns of their use if they really have nowhere safe that they can be. And then two of the things that I think are most important and really have an impact on people's lives are having a purpose, so engaging in meaningful daily activities, and having the independence, income, and resources to participate in society. So in other words, having a reason to get up every day. If you've been actively using for a long time and perhaps are estranged from most of the people in your lives and have lost sight of your purpose as to why you're here, it can be really challenging to think about living without using. And so often the conversations that I would have with my patients who were embarking on trying not to use was helping them to see that their purpose comes from however they see themselves and things that they can think that they would like to do in their lives, or things that bring them pleasure or a reason to get up every day. And that can often take a while for people who have been using for a long time, who maybe do not see themselves as having a purpose, to find that. And so helping to support them while they're trying to find their purpose is exceedingly important. And then lastly is community. So having relationships and social networks that provide support, friendship, love, and hope. So often when patients come into care, they may have some relationships, but often they're transactional relationships. And these are not necessarily healthy relationships or healthy social networks. And sometimes they're codependent relationships with family or friends or partners or social networks. So really finding a new way to have a relationship that's healthier and that's supportive of them. So what are some clinical considerations when you think about mitigating risk? So harm reduction is an evidence-based practice that can be utilized within the spirit of person-centered care. So what does that look like? So the person sets the direction of the process. So for example, I don't want to stop using heroin, but I don't want to die. So you can give or prescribe naloxone in this situation and advise regarding or provide fentanyl test strips. Again, with fentanyl test strips, individuals then are empowered to make a decision based on the result of that fentanyl test strip. So if the substance they were about to use has fentanyl in it per the fentanyl test strip, they may make a decision about how to use differently. Maybe they'll opt not to use that particular batch at all, or maybe they'll opt to do a test dose and make sure that it's safe before they use more. Or maybe they would use the strategy of start low and go slow. So in other words, take small, very small doses to achieve the effect rather than taking one larger dose. Goals are set that are most important to the person. For example, I'm going to use heroin with other people around me and use a clean needle each time. So in this situation, you could prescribe syringes or give information regarding a local SSP or syringe service program. The person's strengths, abilities, and preferences are highlighted. You have created a plan that will allow you to use in a safer way. So you can utilize the New York State Department of Health Build a Safety Plan, which is available at that website, and you can obtain copies of that in English or Spanish to share with your patients. So we've listed some resources here. Dr. Hennessy's part of the talk on suicide. There are some resources here and some references as well. And with respect to overdose, I've listed some resources here as well as some references. We hope that our 4 talks have given you the tools you need to think about decreasing risk or mitigating medical legal risk with your patients who have substance use disorder. Dean, do you want to close us out?
I want to thank our presenters for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.